The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. It's good to be with you again. I want to remind you again tonight, we are doing a pre-recorded program. Since the start of this year, we have been unfortunately having to do pre-recorded programs because my Wednesday nights are quite booked. And I know a lot of you who look on, you like to call in and ask questions. So we're going to give you a few telephone numbers later on. If you have pressing questions, you'll be able to call in to those numbers and ask your questions. So Your Health, Your Choice. As you know, many of you who are our regular viewers, it's all about you making right choices about your health. And health is all about choices. And tonight we're going to be talking about diabetic eye disease, diabetic eye screening. And this is an extremely important area. Now, over the last few weeks, I've departed from my comfort zone. And we've been talking about back pain and cardiovascular disease. But we're coming back to my comfort area, diabetes. So tonight I'm very pleased to have two guests with us. We have Leanne Lazarus.
Yes.
Leanne, good to have you with us.
Thank you.
Leanne, you worked for quite a number of years with the Southwest Regional Health Authority, yes?
Yes.
You want to tell us a little bit about that?
Okay, so I was trained by Professor David Owen. Southwest brought him in, trained us to look for diabetic eye disease. He trained us for about a year. We've been running that program for about 5 years now. They are only located in Southwest, so it's very limited in what they could do for the diabetic population in terms of eye disease. And
right, and now you've made a transition to the Trinidad and Tobago Eye Hospital.
Yes.
So we're going to talk a little bit about that in a few minutes.
Yes.
But I've been very involved. I work for the Southwest region also.
Yes.
And of course, we've both been very involved with the screening process.
Yes.
Unfortunately, it was supposed to be rolled out to the rest of the country,
Yes.
but economics, we're having severe challenges getting that program rolled out to the rest of the country. It's my great pleasure to have Dr. Vinay Kumar. Welcome, Dr. Kumar.
Thank you, Dr. Khan.
You completed your medical school training in India in ophthalmology, but then you migrated to the UK and completed your ophthalmology training in the UK. I was saying that I myself spent about 15 years and then decided to come back to sweet TNT, Trinidad and Tobago. You completed your FRCS with the Royal College of Surgeons, and currently you're consultant ophthalmologist at the Wirral University Teaching Hospital. But not just that, you're clinical lead for the Wirral Diabetic Eye Screening Program, an advisor for the Trinidad and Tobago Eye Screening Program, and you're very keen, passionate, I would say, in reducing the prevalence of blindness. So welcome to Trinidad and Tobago.
Thank you very much.
And welcome to Your Health, Your Choice.
Thank you.
So what we're going to do tonight is we're going to talk a little bit about diabetes and why it causes so much problems with the eyes. And I'm going to ask Josh to bring up slide 3. Slide 3. Right, so we have slide 3 on. Dr. Kumar, would you just take us through this very simply, as it's a lay population we are talking to? What is this slide telling us?
So diabetes, as Dr. Khan has pointed out, is something that affects the blood vessels in the body. It affects the small blood vessels in the body and the big blood vessels. So the little blood vessels that are present within the eyes are what I'm going to be talking about in this slide. It goes through a structural change when the blood sugar is too high, when the normal structure is broken down. And with time, what happens is they start leaking or producing new vessels and ultimately end up closing.
Right.
So this is something which we physically cannot see. And this happens continuously. And we hope through the screening, we're going to be able to pick up these changes.
Because, I was saying just before the start of the program, one of the problems we face here in Trinidad is that people don't often see the need to visit their doctors regularly. And unlike the NHS system, we don't have a system of follow-up. I mean, I well remember practicing in Kent, where we would have our list of patients in our practice, and we could recall those patients every year. And in fact, we had to reach targets, as you know.
Absolutely.
The big thing that I ran away from, all these targets. And you had to demonstrate that you were screening a certain number of your diabetic patients, and on the basis of that, your performance would be adjusted or judged. Leanne,
yeah.
Well, we've talked a little bit about diabetic retinopathy, but diabetic eye screening.
Yeah.
Digital diabetic eye screening. Can you tell us a little bit about that, because you've been involved in that process for the last 5 years?
Yeah. So digital fundus photography is taking pictures of the back of the eyes. What it allows us to do is monitor diabetic changes and the progression of disease if it's present. It gives us the opportunity to monitor that patient, encourage them to change their lifestyle, become more physically active, eat better. All these changes can help the progression of eye disease and hopefully prevent them from losing their sight.
Mm-hmm. And you've been doing that, and the team has been doing that in the Southwest region.
Yes.
In fact, I'll proudly say, we have been the only region
yes.
on the government service to have been able to do that.
Yes.
And we were able to do that with the Johns Hopkins Initiative,
mm-hmm.
as well as with Professor David Owens,
yes.
Who we are very good friends with, and I hope he's able to come back and
yes.
continue some of the work that he started. So that program started about 5 years ago,
yes.
And we've had a lot of success with that.
Mm-hmm.
I mean, we could probably talk about that, the kind of pickup rates
yes.
that we've been having, detecting early diabetic retinopathy and even later eye disease. But the problem has been the capacity to treat.
Yes.
That has been the argument.
Yes.
Now, Dr. Kumar, in England, I mean, of course, you have maybe hundreds of ophthalmologists, mm-hmm. and you have so many hospitals. But one of the arguments that we had in the early days about diabetic eye screening from even the ophthalmologist is, okay, so we're going to screen all these people, but how are we going to treat them?
Yeah.
Any responses on that?
You're absolutely right, Dr. Khan. That is one of the fundamental things and the most difficult challenges in ensuring that you have a system which can deal with treating patients and not just screening patients. Mm-hmm. So this is all together, and that's very important. It's an end-to-end program. Mm-hmm. And as you rightly pointed out earlier on, it's a call-recall system.
Yes.
So what I have learned in actually working on the middle diabetic eye screening program and learning a little bit of public health ophthalmology is that a screening system allows you to pick up disease at a very early stage. Mm-hmm. Not all the patients need to be seen in a hospital.
Right.
So it's only a small percentage of them that needs to be referred into the hospital. Yeah. And that group is called with somebody with sight-threatening diabetic retinopathy. Mm. So we have pathways. We have parameters as to how do we define the sight-threatening diabetic retinopathy. So once we detect who they are, so in our service where we work, we detected it's about 5 to 10% who need to be referred into the hospital. Mm-hmm. And then you build systems in your own service that can cope with that 5 to 10% and offer them treatment.
Right.
Otherwise, we would be definitely failing the whole screening if we do not have the treatment option for these patients.
Now, I'm not sure if I'm correct on this, Leanne, but I remember Dr. Ronnie Bowler, who was really very much involved in leading this program in the early days, telling me that they were picking up about 30 to 40% of eye-threatening diabetic retinopathy. 30 to 40%. Now, these are people, Dr. Kumar, and I don't want to shock you, who have been coming to our clinics, not my clinic, hasten to add. But just to say, my job in the Southwest was to set up specialty community diabetic clinics, but then we have the chronic disease clinics that go on a daily basis in the various primary healthcare centers. And there was a survey done, and a lot of these patients have been coming for years.
Yeah.
And they've never been told, unfortunately. And I know I get into controversies and I say things that may offend people, but they were never told that they needed to have regular eye examinations, etc. So we're going to come back again to the difference between the optometrist and ophthalmologist, etc. But our pickup rate was somewhere between 30 to 40%, which was
very high,
which is astounding.
Yeah.
So and part of the problem was that people were being referred for review in 2 weeks or 3 weeks, and I think in the early days there was just not enough capacity to deal with that.
Yes, just to add to what you've just said, having spoken to Dr. Bola, that was one of the biggest concerns when he spoke to me about it. And we said we need to have a system which captures this data for us to know what is exactly going on and how you can translate. So you did ask me earlier on what was the prevalence of diabetes. So in a country like UK or Europe, you have 6 to 7% as the prevalence of diabetic retinopathy. But in Trinidad and Tobago, it's about 11 to 15%.
Right.
That's very high. It's pretty much double the figures actually you're dealing with. So we were discussing yesterday that 1 in 6 persons in Trinidad and Tobago could be or is a diabetic.
Right. Okay.
That's huge.
And that's the kind of figures we've been looking at. I mean, we are probably number 2 or 3 in the Western world, and quite high up. I think it's just the Middle Eastern countries like Saudi Arabia, Dubai, etc., that have higher rates of diabetes. So at least we're leading in one thing. Unfortunately, it's not something that we want to lead in. I just want to give the telephone numbers at this stage, at the start. Now, one telephone number you can ring, it's our telephone number, the Anapopsis Center, 482-4269. But you have a telephone number if people are interested in ringing to find out about the Diabetic Eye Screening Program. What is the number?
That number is 298-3572.
The 298-3572. Okay. So we'll keep repeating those numbers, 298-3572. I want to bring up slide 4, if we can bring up slide 4. And right. So, Dr. Kumar, could you just take us through this particular slide?
Okay. So this particular slide is a sequence of events that happens in somebody's eye when it is not paid attention to could end up. So what you're seeing in this slide is a lot of scar tissue on the surface of the retina, which is pretty much end-stage diabetic retinopathy.
Right.
You're walking into an eye clinic or to your physician with pretty much blindness in one or both eyes.
Yeah.
Our intention with any screening program is to prevent this happening.
Okay.
So we can do it.
So we can just come off that slide. But how long would this process, very often patients are referred to me from my ophthalmology colleagues, and they already have advanced diabetic retinopathy. And, you have a patient coming into you and they're saying, well, I've only had diabetes for 2 years. And how would you respond to that?
Okay. It's a very interesting question, and it's an oft-repeated thing, and they present to optometrist as well, and coincidentally, it's picked up changes at the back of the eyes. So if you look at, as you know, Dr. Khan, there's 90% of the diabetics are type 2, when we're talking about even Trinidad and Tobago, or even the world across. 10% are type 1. So type 2 diabetics invariably don't know they're diabetics until they've arrived at an optometrist or to an eye clinic to get their eyes, to get their physical examination checked. It's only when we do photographs, we see changes that have far preceded their presentation date. So what we've understood with evidence is that most people develop changes in their eyes after being a diabetic for about 10 years. That is what we've understood.
Right.
So 10 years is something that people would have had before they established changes. So if somebody does not know they've had a diabetic for 10 years and have had poor control for 10 years before they start taking medication, so you would end up coming in the 10th year or the 11th year with actually advanced changes at the back of the eyes.
Right. And unfortunately, we are seeing that on such a regular basis. Patients, I have ophthalmologists ringing me, and fortunately, I have a good relationship with a lot of the ophthalmologists, and by the time they're referred for what I do, which is controlling their blood pressure, and we'll come to that, the risk factors. Patients are saying, well, can this be reversed? What can I do, etc. We're going to come back to that. But Leanne, how will someone know that they need to be screened for diabetic retinopathy? So they're diabetic.
Yes.
And someone says to you, well, how do I know I need to be screened?
Once you're diabetic, you need to be screened every year.
Okay, so I want you to say that again.
Once you are diabetic, you need to be screened every year. It's very, very, very important.
Okay, so right now, we have the diabetic screening program in the Southwest region.
Yeah.
I know some of the individual ophthalmologists have cameras in their practice, but as far as I'm aware, there's no systematic screening program.
Yeah.
And maybe, Dr. Kumari, when I say systematic screening program, you can let our viewing public know what I mean by that.
Yes. So it's very important to understand that when you're offering screening service, that there are various aspects taken care of. So inviting somebody to come into a screening program means taking fundus photographs and grading the pictures to see if there's any diabetic retinopathy changes, feeding back information to the patient and to the referring physician of the optometrist, and keeping them as a database to monitor the patient for the following year. If the patient comes back next year and there is demonstrable evidence that there is progress, you educate the patient at the same time about change. So this is the governance structure that is very important. And the process can be managed using the technology that's available. So in the UK, we use a software to manage right from the initial process, which allows us to keep all the data in one place, report back to the patient and to the relevant personnel, and also understand that what are you offering as a service, how many patients I have retinopathy, how many you've referred into the hospital, whether you've done it in the right time span that you want. So drawing up all these pathways, the governance structures is what we're talking about as a structured fashion of doing something.
Okay, well, I've been told we need to go to our first break. So we're going to go to about a minute's break, and we're going to come back, continue this discussion. I want to remind you we are on a pre-recorded program, so you can't make any live calls in. But when we come back, we're going to continue talking about the Diabetic Eye Screening program, and I'm going to get a little bit into what the Trinidad and Tobago Eye Hospital is actually doing. You're watching Your Health, Your Choice. We'll return in about 1 minute's time.
We supply all sizes in digital, outdoor, and indoor signage, both sales and rentals. Be seen with huge, clean, and crisp screens from the Creation Group. Think ahead, stay ahead with the Creation Group of companies, located at 2A Arapita Avenue, Woodbrook.
We are taking it to higher heights in 2018. Yes, that's right. Cloud9 is going live at 5. The show that makes you smile will have you smiling even more as we're coming to you from 5 p.m. Mondays to Fridays right here on HCTN The Voice. Get ready for liftoff.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. You're watching ACTN The Voice.
When you do not start your process with God at the center, it will always end in disappointment. There is no significance to any process that God is not the center of. I don't believe anything more than I believe that. To neglect your priorities is to forfeit your provision. There's never a lack of provision in God. Never. Everything that you need is already here. There is never a lack of provision. So the problem of the people in the way they experienced it was a problem with provision. Haggai said, it's not provision. Consider your ways. What you think is a lack of provision is a lack of priority.
Well, welcome back to Your Health, Your Choice. This program is going to be aired on the 21st of March, which is Wednesday night. So you're looking at it on Wednesday night, but it's pre-recorded. So unfortunately, you're not able to make any call-in live calls tonight, as you usually do. So if you have questions about the program, I'm going to give you the first number, which is 298-3572. Now, that's about the Diabetic Eye Screening program, all that we're talking tonight. If you want to find out more about just general diabetic treatment, then the number to call is for the Anaposa Center, 482-4269. Dr. Kumar, we have another slide here. This is slide 5. And this is the impact of diabetic retinopathy, which I thought was quite interesting, the diagram. So slide 5.
Having been fortunate to participate in the screening program in the Wirral, and being a retinal specialist myself, I have seen the patients from the screening and the patients in the clinic. What really hurts me is that young patients who are walking into the clinic pretty much blind, and no matter what we tend to do for them, we're unable to pull back. So this slide talks about the fact that blindness means that it can take away the fact that you can not see your near and dear ones, takes away your independence of being able to get about driving and the favorite cars that you have. You would be registered blind and you would be dependent on someone. And unfortunately, fretting at that point of time in the hope that we can reverse the cycle is an impossible task. So my ask and request to every diabetic is get your eyes screened every year. Prevent the risk of going blind from diabetes, which is entirely preventable as much as possible.
So, one of the things we struggle with is patients coming in and saying, well, doc, I went and I had laser done and my eyes are now worse than it was before. I went and had injections done, and so I've been told, or a patient may come in and they've been told by the ophthalmologist they either need Avastin injections or laser treatment, and a neighbor or friend has said to them, well, that's going to make your eyes worse. And I've heard that repeatedly. I mean, how would you respond to a patient telling you that?
It is very difficult. And when we hear about this particular thing from the patient, it's the apprehension and poor education to the patient about the current situation, why treatment is being offered. As I said earlier on, out of every 100 diabetics, usually about only 5 to 10 might need treatment. So the 90 do not need treatment, and we actually don't pay attention to that at all. So amongst the 5 to 10 of them, when they walk into our clinic, we evaluate what is the state of the back of the eyes. We study using various equipment that is available to us to the extent of damage that is there at the back, and then discuss about the options of treatment. And what has been established, for example, what he spoke about, the laser treatment, is used to reduce bleeding inside the eyes. That is to minimize the risk of new blood vessels which have developed. So you need to treat 2 patients to benefit 1 person.
Right.
This is how powerful this has been and has been around for a large number of years. It is one big thing that reduces severe visual loss in these diabetics. Similarly, we have, in the last 10 years, injections being made available for diabetic retinopathy, particularly for maculopathy.
Yeah.
That is where the injections come in. But people need to understand, and the patients need to understand, that there is damage when you've already come in. We're trying to minimize the extent of damage as much as possible with treatment. And we, as physicians and providers of care, we need to handhold the patient and support them during this process. And that is very important for us.
Yeah. I think there's a lot of misinformation in Trinidad. I'm not sure what it's like in the UK now, but we have a lot of kickback from our friends in the herbal community. And I'm quite outspoken. I've been criticized on Facebook, etc., saying that I'm anti-herbal treatments, etc., etc. Well, I am. I am. Sorry, Dr. Kumar, I'm very outspoken. Because most of these treatments are not scientifically proven. What we call, how we do science is we judge our treatments on the basis of double-blind, placebo-controlled trials, which I wouldn't go into today, but really we need to be very careful. You know, I've heard some crazy things. Patients going to herbalists and being given eye drops and being told to put these drops in their eyes, and they don't have a clue what these drops are. But we'll come back to that. Leanne, tell us a little bit about the Trinidad and Tobago Eye Hospital and the screening program that is being set up.
Okay, so our aim, as Dr. Kumar said, is to reduce blindness. What we want to do is invite diabetics to come in and have their eyes checked. We invite them for an appointment. They will be told about the screening process, that they need to have someone accompany them because they will be dilated. Dilation is going to leave you a little bit blurred. So we ask that they don't drive after. Right. When they come for the appointment, we take a short medical history. We take a visual acuity, which just gives us an assessment of how good their vision is, and then they are dilated.
So can I ask you, who is actually doing this initial process?
Okay.
The history taking, putting the drops in, etc. Is it a doctor or is it someone who has been trained specifically to do this process?
So it's a clinic aide and a retinal photographer who will be doing the initial process. They've been trained and know what the exact processes are, what they should look for if a problem should arise, and they go through the screening process with the patient, make sure that they are comfortable before they are dilated, and then we take the pictures of the back of the eyes. These pictures are then sent to our grading center. At the grading center, we will evaluate the level of eye disease, categorize it, and determine if there is no eye disease present, if the situation is severe.
Right.
If there is sight-threatening diabetic changes to the eye, what we do is refer them to the eye clinic to go and see an ophthalmologist.
Right. Now, okay, so we're talking now, so I want to be clear so that our audience understands this.
Yes.
We've had the diabetic screening program in the Southwest region.
Yes.
I have to say it's been a little bit patchy in some areas, I have to tell you, because there are some people who have been screened, say, in 2015, and they were supposed to be called back in a year, and they've now been waiting for 18 months to 2 years to be called back. Now, I know that's an economic argument, so I don't want to get into that. But it's a great initiative that was started. Now, what we are talking about here is a private initiative, am I right? Yes,
it is.
Okay, so patients will have to pay for this screening. And I don't want to get into the cost right now. Again, if you want to find out more, and I just want to emphasize how important this process is that we're talking about. It's $298 3572. 298-3572. So the whole process from the patient walking through the door to getting the history taken,
Yes.
To having the drops,
Yes.
having the photographs,
Yes.
how long would that process take?
It takes about 30 minutes.
Okay,
Yes.
fine. And you're able to screen roughly right now how many patients per day?
Per day, about 25 to 30.
About 25 to 30.
Yes.
And we'll get back to your locations,
Yes.
etc. Dr. Kumar, I have to say, having spent 15 years in the UK, I worked at a diabetic center in Kent, Chatham Medway Hospital, and the screening program was up and going. We had an ophthalmologist who would come in on the day and be in one of the rooms looking at the photographs, and we would be doing our diabetic clinics, etc. I'm not sure if it's a similar process that you do, but it was a fantastic setup. When I came back in 2006, of course, we had nothing like that. So this has been a tremendous foot forward. But the question I want to ask, I want to just bring up slide 6, I think. Yes, slide 6. Because we want to just talk about treatment options. But the first thing is about how we can prevent retinopathy.
Absolutely.
Yeah.
So as you spoke about it and allude to it, 90 out of 100 may not have used amount of sight-threatening retinopathy. That is because they have done a good job of controlling their blood sugars and blood pressure, which are the risk factors in diabetic retinopathy. And we know about that through established, as you rightly said, about studies that have been done and shown its benefits. So we re-emphasize to the patient and the patient's family about diabetic control, how to go about improving things. And even when they have sight-threatening retinopathy, it's important that they don't walk away from the clinic and drop their blood sugars dramatically, because that would damage their eyes far more aggressively, because it's a systemic disease where the eyes have got problems. So we need to work with them and try and help them understand these aspects. So in my practice, I try and make an effort to actually talk to the patients, and if there are carers or family members, involve them, because this is just not an individual problem. And this is where we need to bring all of them together.
Right. Now, you've made an important point, and I remember Dr. Bowler doing a lecture for us at the Diabetes Academy, which is an institution that we have set up. And he did make the point that if patients come into us and their blood sugars are extremely high, and they already have advanced retinopathy, and we're going to put them on insulin treatment, we need to let them know, because retinopathy can actually get worse.
Absolutely.
Now, I think a lot of us as physicians are not always aware of that.
Correct.
And we may not always tell our patients that. So, do you actually work closely with the diabetologists?
Absolutely.
Right.
So we have links with the diabetologists, diabetic nurses, and also actually advise patients to contact us if there was any problems. I do not get into the management of diabetes, but we try and link people up. And one of the vulnerable groups amongst the diabetics are the pregnant diabetics. So in this situation, we work with the obstetricians, where a patient who's got poor disease needs to be managed very closely, which simply means that accommodating them in your clinics at a very frequent period of time. I've had patients in the last 3 months where I've seen them every 2 weeks to monitor them so closely. And in fact, the obstetrician comes up to ask me whether we should induce this baby before to protect this patient's eyes. These are complex decisions to be made. But we want to see if we can prevent it completely as much as possible. And again, coming back to the issue that screening, even of this vulnerable group, in the UK is done every 3 months, which allows us to understand the importance of diabetes in the pregnant mothers. So we need to support them. We need to emphasize to them that they need to see their baby after they've delivered. So it's, again, a lot of work in building that relationships with all your support people as well. Just stepping back a little bit, the screening program where we deliver on the Wirral is with optometry, primary screening in the community. So we work together as a team.
With the optometrist?
Yes.
Okay, so key question.
Yeah.
What is the difference between an optometrist and an ophthalmologist?
A tough question.
I'm putting you on the spot here.
Okay, I'll start with the easy one, which is the ophthalmologist. Me, that is medically qualified and actually done some training in ophthalmology. That is called as an ophthalmologist. Optometrists are who are also qualified, but not necessarily medically qualified, but they train going through a program within their respective country and provide care within the community or in the hospital in refracting, prescribing, making some, where you have specialist optometrists who are able to participate in screening and various other roles. So these, which we in the UK call as enhanced or advanced optometry roles, for which they do specialist programs, diplomas, and educate themselves and participate.
Right.
So we have, just to give you an example, a glaucoma module for optometrists, diabetic module for optometrists, so on and so forth, which helps.
I remember when I was doing my specialist registrar training in diabetes in Poole in Dorset. Dr. Jones, was he? He was one of the first, this was in the 70s, I think he was one of the first ophthalmologists to set up this program with the optometrists in the community. And he was a pioneer in that aspect.
I'm aware of the Poole program way back, and it's a very good friend works in Bournemouth. And they tell me about, they were ahead of the times.
Absolutely. Well, we're going to have to go to our second break, and we're going to come back, and then we have about 15 to 20 minutes left. But I want to remind you of the number to ring if you have questions about the diabetic screening program from the Trinidad and Tobago Eye Hospital. The number is 298-3572. 298-3572. So we're going to go to our second break, and then we'll come back to your health, your choice, and we're going to wind up talking a little bit more about the Trinidad and Tobago Eye Hospital and maybe a little bit more about some of the treatments available. You're watching Your Health, Your Choice. We'll return in about a minute's time.
We are taking you to higher heights in 2018. Yes, that's right. Cloud9 is going live at 5. The show that makes you smile will have you smiling even more as we're coming to you from 5 p.m. Mondays to Fridays right here on ACTN The Voice. Get ready for liftoff.
Be original, be unique with digital advertising through the Creation Group of companies. Over 30 locations with over 178K viewers per day to meet your target audience. Be seen with digital advertising from the Creation Group, located at 2A R. Peter Avenue, Woodbrook.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. You're watching ACTN The Voice.
But it's okay, because I got my own grace. I got my own grace. I don't need yours. I got my own. And I will not waste the grace of this day. This is the day that the Lord has made. I will rejoice and be glad in it. I refuse to leave any grace misappropriated.
Welcome back to Your Health, Your Choice. We're on our final segment tonight, and we're talking about diabetic eye screening, the problems with diabetes in the eyes, trying to prevent the late complications of diabetes where eyes are concerned. We have Dr. Vinay Kumar, who is an ophthalmologist from Liverpool. Wirral.
Yes.
Is that near Liverpool?
Yes, near Liverpool.
Okay. My wife recently visited some friends in Liverpool. It's very cold, though.
Currently very cold at this point of time.
That's why I returned to Trinidad.
I can see that.
Leanne, we're going to just cover briefly, Dr. Kumar, some of the other treatments we have. But Leanne, how do people get appointments to the Trinidad and Tobago Eye Hospital, and where are you located at the present time?
Okay, so to make an appointment, they can call the number at 298-3572.
Okay, same number, yeah.
Yes. And right now we're in Freeport. If you need the location, you could look at the Trinidad Eye Hospital website. That's trinidadihospital.org. It'll give you directions to the location. We want to roll out to other locations in San Fernando, St. Augustine, and Maraval.
Right.
To be able to screen the whole of Trinidad.
Okay. Now, again, I'm saying this is in the private sector.
Yes.
And hopefully the medical insurance companies will cover some of the costs. But from what I'm hearing, it's not that expensive for a screening. So do you have an average cost at the present time, or you want to?
Well, when we have an average cost of around 400,
right.
But there's also subsidized pricing for people who belong to the hospital as well, which should be around 200.
Yeah.
So our aim is to make it affordable for people.
And let me say, I mean, to have your eyes screened for 400, and this is a photographs at the back of the eyes, or slightly less, is an amazing price, in my opinion. So it is something that we need to consider. So the program, is it up and going as yet? Or,
yes.
Right. So it's already up and going.
Yeah.
And you're now in the process of expanding.
Yeah.
Dr. Kumar, sorry, I'm rushing a little bit because we don't have a lot of time left. But in terms of other treatments, we talked a little bit about laser. We talked about these injections. When people hear about getting an injection in the eye, there's a lot of fear. But is it very painful?
No.
Right.
Is all I can say. We run injection services. The procedure of giving injections, as far as I'm aware, which I do personally as well, is we put plenty of local anesthetic into the patient's eyes after having explained what the purpose of the injection is for, obtaining the consent. Then we put some antiseptic into the eyes, and we give the injection into the eyes. Normally, these patients recover within about 1 hour or so.
Right.
And we advise them to take it easy for the rest of the day, but they're able to get back to work the following day.
Right. Are all ophthalmologists qualified to do laser? You're smiling when I ask this question. But, we have now vitreoretinal surgeons.
Yes.
People like Dr. Bowler, and I think you are a vitreoretinal surgeon. So that's a more advanced training. But normally, in terms of in your ophthalmology training, are you able to, most ophthalmologists would be able to do laser and injections?
Current trainees are able to do. Even my period when we were trained, we're able to do laser, which is part of our training.
Right.
Not a difficulty. And injections, again, is not a difficulty, can be done. But what I would like to emphasize out here is that we have to be careful in providing care for this patient, that it's continuity of managing a given patient. It's not a one-off treatment and then forgotten.
Absolutely.
So where we come into the region of medical retinal specialist or vitreoretinal specialist or a general ophthalmologist, as long as they're comfortable in doing it, and the continuity of care. That is very important. It's important to understand that the injections benefit last for a short period of time.
Right.
And some patients require a lot of injections. So on an average, in a given 12 months, they might require about 8 injections. So it's important to understand whether you have the infrastructure to deliver this, monitor patients at every regular period of time. If you have the infrastructure, I think it is good for them to participate. But if you don't, then the retinal specialists are there to help you out.
And I think one of the problems we're facing is that we don't have electronic health records. In fact, having come from the UK where we were completely paperless, I came back to a system where we went back to paper notes. And at the present time in my practice, I'm trying to get that up and going again. But without the electronic records, what I find is patients are coming to me as their diabetic physician, and I'm asking them, well, you know, you had an Avastin injection last year. Have you been back? Well, no, I haven't, because I wasn't told I needed to come back. So I said, but you had one injection, so really you should have been seen. And I'm sure the ophthalmologist would have said to them they needed to be seen in 2 months or 3 months. But I think that's one of the problems we're having right now, the follow-up.
Very important question, Dr. Khan, because remember earlier we spoke about a system, and we call this as fail-safe. It's a very important component within any given screening service. So fail-safe within clinics and within screening are 2 aspects that we need to understand. Like as you described, if a patient does not turn back to the clinic, we need to understand why. So we're hoping that once the system is got a lot of patients, that we're able to contact the patient as to why you have not turned up, because you're supposed to turn up. Because if they come back to you in a year's time with loss of vision, that's a failure on the service providers.
Yeah. Well, we have about 10 more minutes, and we still have so much to talk about. Maybe we'll have to do a second program when you're next in Trinidad, which I hope will be soon. Leanne, the graders, this is one of the final questions I wanted to ask you. So they are photographers. Are they the same as the graders, the people who are doing the grading?
Well, when I was in Southwest, we were trained to do both. So we're capable of doing both the photography and the grading. But we want to make it so that you specialize in one or the other. Yes.
Now, I remember Professor David Owen saying to me that he did, I'm sorry to say this to you, Dr. Kumar, he did a survey. He had a number of ophthalmologists in a room in the early days with the screening program, and a lot of the ophthalmologists were actually missing retinopathy, and he felt his graders who were trained were better at picking up early retinopathy and then referring on to the ophthalmologist. I don't know if I'm any comments on that?
No, actually, I wouldn't disagree with you. What is important to understand is that the graders see a lot of normals or minimal retinopathy. So they're very good at trained actually to pick that up. I'm actually seeing only the end of it, spectrum, which is a small, and I see only disease, so which is a slight difference. Yes, and graders see them much more often than we do. And it's important. And I believe that we work in a team, and it's important that all of us continue to learn and interact with each other. Without a teamwork, no screening program will work.
And, you know, that's one of the challenges we have right now in Trinidad. We are still very doctor-centric. And getting people to understand that, for example, we've been successful now in our own program training diabetes educators. But to get people to understand that your physician is not going to do a lot of diabetes education, that you need to see a diabetes educator, is often quite a challenge. And that's one of the things we are working with. Hopefully, I know my vision coming back to Trinidad was to set up, and it is still to set up a holistic diabetes program, a diabetic center, where we have diabetic educators very much as part of that process. But the reason I asked the question to you, Leanne, is that people may say, well, are you a doctor? And you're going to have to explain to them what your training is and how effective it is. Okay. So we have just about 5 more minutes, Dr. Kumar. Can we just talk quickly about the risk factors I'm just going to bring up, I think this is slide 7. Slide 7. Yep, slide 7. Could you just take us through this quickly?
Very quickly, you alluded to the fact that you want to have a holistic care for the diabetics, and that's where we participate as retinal physicians in contributing our bit to it. But what is important to understand that is there is a modifiable factors such as diabetic control, which you emphasize, blood pressure and lipids. There are certain non-modifiable factors, which is genetic factors. Coming from the Indian background, we are at a high risk of developing, and Trinidad has about 40% of them. Duration of diabetes. One of the important things to understand is smoking. If you can avoid smoking and you're a diabetic, it makes matters worse. So diabetic educators working as a team, diabetic physician, doctors who look after diabetic eye diseases, people who screen, we're all a team.
Right.
We need to understand that to raise the awareness amongst the public and change the attitude towards approaching this problem.
Okay. I don't want to miss this out because you have several seminars coming up. I don't know if Leanne or Dr. Kumar, you want to tell us a little bit about the seminars that are coming up over the next 3 days?
Yeah. Okay, so the seminars are starting today, which is the 20th. We will be in Shoguness today, as well as tomorrow at the Shoguness Borough Corporation, I believe it is. And on Thursday at the Naparima Girls High School. It's for the optometrist this evening, and the other 2 days are for the doctors.
Okay, so our place is already filled?
Come along?
Yes.
Okay, so it's the same number that you can ring if you're interested.
You can call that number,
So
yes.
again, if you're an optometrist looking on, unfortunately, well, sorry, you're going to be seeing this program tomorrow night.
Yeah.
But I'll still give you the numbers. It's 298-3572, because even if you miss these series of seminars, you can, and the next time we have a round of seminars, you'll have the number. So 298-3572. Dr. Kumar, we only have about 5 more minutes. What are some of the other eye problems, diabetes problems that you're seeing with the eyes?
It's a very important question. While we are screening for diabetic eye disease specifically, we should not forget that diabetics are at an increased risk of developing cataracts.
Right.
The cataracts actually makes it difficult sometimes for us to take the fundus photographs.
Yeah.
So we need to clear the cataracts to take clear fundus photographs to evaluate and determine what the disease is. And they're also at a higher risk of developing glaucoma compared to the average non-diabetic. And it's a very important thing because the Caribbean population have a higher risk of developing glaucoma, and blindness resulting from glaucoma. And there's a lot of work that's being done at this point of time. So we want to raise awareness, not just about diabetic eye retinopathy, that these patients are at high risk of developing cataracts and glaucoma and other eye diseases, which we want to raise awareness through the public forums and the platforms that we're doing.
Right. We have one last slide I wanted to cover, which is slide 13. So, Dr. Kumar, you probably can just take us through this, slide 13. Just tell us a little bit about this.
Very important slide. It gives you a snapshot about what is happening currently in the world. Currently, we have about 450 million diabetics who we know.
Yeah.
There might be much more. In the next 15 years, that will increase by about 30%. And as you earlier on pointed out, Western Hemisphere in countries like the Caribbean, which would go up much more, India, much more. But very important that we work as a team to reduce blindness. And that is our ambition out here.
Yes.
Where we can prevent, we will prevent. But you need to come and seek help for us, with us.
I think the saddest thing for me is, when I do my clinics on the government service as well as in my private practice, seeing a 45-year-old in the midst of their working life and now being unable to earn, and the repercussions of that in terms of for the rest of the family is really horrendous.
Yeah.
And I think preventing blindness is really a tag that I think you're trying to emphasize. That this whole program from the Trinidad and Tobago Eye Hospital, it's about preventing blindness.
Absolutely, because the UK model has demonstrated that over the number of years. 10 years ago, blindness in the working age group was diabetic retinopathy. It has fallen down to the third now because of introduction of this digital eye screening program. That's commendable. And when we have evidence that screening can make a difference, why not do it?
Yes.
Why should we avoid any place to be not having screening program? And that's why when the team approached me, I said we should make it happen.
Leanne, in closing, the Trinidad and Tobago Eye Hospital, the screening program is now based at Freeport.
Yes.
The number again, I want to give you that number. I know I've been repeating it. It's 298-3572, 298-3572. Any closing remarks you'd like to make?
I just want to emphasize what Dr. Kumar says, that it's very, very important. Once you're diabetic, you have your eyes checked every year. Our aim is to reduce blindness. That is what I came into the Trinidad Eye Hospital to do, and that is what I really hope we can do with this program.
Right. And Dr. Kumar, any closing remarks?
All I would say is that we're here with you, but we need you to participate with us to help you avoid going blind.
Yes.
And it is you who can make the difference, and we are here to help you.
So thank you very much, Dr. Kumar, Leanne, for joining us. Thank you for the Trinidad and Tobago Eye Hospital. Dr. Ronnie Bowler, who is leading this program. We are very good friends, and I'm hoping that we're able to do some work together as well in the future. As I close tonight, I want to remind you that this program is replayed on Thursday at 1 p.m. on the same station, ACTN, and then Sunday nights at 7 p.m. So it's going to be replayed on Thursday at 1 p.m. and Sunday nights, and it's going to be replayed next week. So you have 6 opportunities to look at this program. As I close off tonight, I often put on my pastoral hat. As you know, I'm bivocational, medical doctor as well as pastor. And choices in life are extremely important. We have talked about making choices to have your eyes screened. Extremely important. Because, you know, very often we play a blame game. Things happen to us. Our eyes are affected. Diabetes affects different parts of our body. And then we blame the doctor, the nurses, our husbands, wives, etc. I want to say to you that you have choices to make in every area of your life. You have choices to make where you're going on vacations, being able to take time off from your work, being able to take time off with your family. At our center, the Anaposis Center, we try to emphasize a holistic approach. And I think that's what the Trinidad and Tobago Eye Hospital is doing as well, really applying a holistic approach to life. So as we end tonight, I want to remind you, make wise choices about your health, about your relationships, about your daily work, and about your future. When you come to the end of 2018, don't regret some of the bad choices you have made. I want to thank you for joining us on Your Health, Your Choice. This program, as I said, is going to be replayed for the next week or two, and then we come back maybe with a live program or a pre-recorded program in 2 weeks' time. Thank you very much for joining us. I'm Dr. Claude Khan. We'll see you again soon.